All right. Welcome to everyone to today's conversation, AML biomarkers, how testing shapes your treatment options. I know there's so much going on at and around diagnosis. There's a lot to digest. There's so much information coming at us. And our hope is that you walk away from today's discussion empowered to improve your AML care by maybe knowing more questions to ask your doctors, your healthcare providers, or maybe to advocate for yourself, to understand how to be more engaged in your care. And of course, know your treatment options from biomarkers through clinical trials. If we haven't met before, my name is Stephanie Trong. I'm the founder of The Patient Story. More importantly, I'm a blood cancer patient advocate myself. While I wasn't diagnosed with AML, I was diagnosed with non-Hodgkin lymphoma, and I remember swimming in questions. Things were happening so quickly, and it felt so hard for me to understand what was what. And we don't know what we don't know, right? And so that's why The Patient Story aims to build education as well as community through educational discussions like today's, as well as through our hundreds of in-depth patient stories, all with the goal of amplifying the voices of patients, of care partners. And so for today's discussion, our patient advocate, Steve Buechler, talks with a leading expert in AML treatment, Dr. Steven Strickland from Sarah Cannon Research Institute, and also one of his actual patients. So it's really exciting to be able to have everybody on board like this. We do want to thank our sponsor, Kura Oncology. Its support allows us to share more educational content like this, editorially independent, and free for our communities. The Patient Story retains full editorial control, and while we hope that this is helpful, please keep in mind this is not meant to be a substitute for medical advice, so still consult with your own healthcare team about your decisions. We want to stress also that your voice showing up today is so important to us. Please tell us what you want to learn about, what would be most helpful to you. We want to hear from you about that, and so a survey is going to pop up at the end of this discussion. It should only take a few minutes to fill out, and that will again come on after this program ends. Now, Steve is going to help guide this discussion, but we all agree that it would be really helpful context to understand Steve's story first. So Steve, as an AML patient advocate, we'd love to hear more about what brought you to this point in sharing your story.
My name is Steve Buechler, and I was diagnosed in June of 2016. I did what doctors tell you to do, and that is get a yearly exam. I had no symptoms whatsoever. I thought, I don't really need to do this, but I kept the appointment at the last minute. And as part of the routine annual physical, they did a CBC, and they said, wow, your white blood cell count is dangerously low. And so they referred me to a hematologist/oncologist. He said, we're going to do a bone marrow biopsy. That detected the AML with 50% blasts. And from there, we were off to the races. I was hospitalized the next day for 37 days with the initial 7+3 treatment, eventually a stem cell transplant. But I had, not only did I not have non-specific symptoms, I didn't have any symptoms whatsoever. Maybe I was a week away from having symptoms. If not for that physical, I probably would have learned about my AML when I was in much rougher shape. Now more than ever, knowing your biomarkers and the mutations and the genetic alterations is absolutely essential. I've heard it said there are dozens of different subtypes of AML based on how those things are present or absent, and many of them respond to different treatments. So you got to know that stuff. Otherwise, to use Dr. Strickland's metaphor, you're just using tanks to blow stuff up. But if you can find something where you have a sniper to target something and minimize side effects and leave the rest of your body in shape, that's the kind of treatment you want to have. And now on to today's discussion. Today we're talking about the importance of testing for biomarkers in AML treatment and how doctors and patients can work together to determine what options are best for them. We're joined by Dr. Stephen A. Strickland, who's the Director of Leukemia Research for Sarah Cannon Research Institute. He's an internationally respected leukemia researcher with more than 100 peer-reviewed scientific publications and abstracts. Also joining us is Joseph, who is one of Dr. Strickland's patients. Joseph, can you tell us a bit about your journey with AML?
Yeah, absolutely. First of all, thanks for having me. My story really started when I was coaching mountain biking. And I noticed over the summer, it was 2 summers ago now, that my legs were becoming very fatigued very quickly. And at a mountain bike race, actually started having chest pain, which led me to an ER. And an ER yielded a CBC that showed extreme concerns for a blood cancer, and then was flown immediately to Sarah Cannon under the care of Dr. Strickland. And it kind of took off from there. It's a wild ride to find out you have leukemia and find out that the treatment options are not something you can weigh and think about for weeks and months, but something that really over the course of days, you got to make some pretty aggressive decisions and start the treatment. So really kind of a whirlwind, if you will.
I well remember it moves really fast. So thank you for that. Today's discussion is an important one, so let's get started. We're going to start by just looking into biomarker testing. So for Dr. Strickland, what are biomarkers and what are the different types? We hear about diagnostic, prognostic, predictive, monitoring. It sounds pretty complicated. Can you sort it out for us?
Well, I think you hit it on the head. It is just that complicated. Historically, as we looked at AML, it was diagnosed simply by looking at cells under a microscope. And we know that those cells can look similarly under the microscope, but the biology of AML is very heterogeneous, very diverse. And looking at these biomarkers can help us to understand the true heterogeneity of those cells, and now help us to predict both prognosis as potential therapeutic opportunities. So there's a lot of different biomarkers that have been developed over the years, and so we have a broader spectrum of testing that we do on every patient now as standard of care at the time of initial diagnosis to really help guide us in our treatment decision making.
For AML in particular, can you describe what biomarkers or what type of biomarkers do you commonly test for?
Sure, it's a great question. So there's different types of biomarkers, and really what we're looking at is the biology of the leukemia cell. There are tests that we look at the cytogenetics or karyotype, what's called a chromosome analysis of the leukemia cell, to see if there are specific genetic aberrations. And those genetic aberrations may inform us in regards to if someone's going to be in a favorable risk group, a high risk group, or an intermediate risk group. And that can have implications for therapies that we may want to consider, or possibly even clinical trials that we want to consider for the patient from the very beginning, but also help to inform us that once we hopefully have the patient in remission, whether or not we need to consider something like stem cell transplant while they're in remission to give them the best chance at a cure. But historically, we've had access to cytogenetics for several decades now. But more recently, the molecular profiling based on what we call as PCR-based tests or single gene assays, and different panels have been developed. And more recently, there's even something called next generation sequencing, which many labs have developed and can be anywhere from, say, 35 to sometimes as many as 200 genetic mutations, if you will, or molecular mutations that can be assessed on these panels. So it's a plethora of information. There are several that are definitely important and have, ever since the early 2000s, have really been encouraged to be tested at the initial diagnosis. Things like FLT3, which we know patients who have at least FLT3 ITDs can often have a higher risk disease biology, especially before the availability of FLT3 inhibitors. We also know IDH inhibitors are available now for patients who have IDH1 or IDH2 mutations, and that's been predominantly and historically in the relapse refractory setting. But again, data is now looking at the incorporation of these IDH inhibitors into frontline therapy as well, and more, recently, not just understanding NPM1, for instance, as a prognostic factor, but also now with the advent and availability of menin inhibitors, we look at the availability of NPM1 as a potential therapeutic target as well. And so there are multiple options. Recently, in the relapse refractory setting, we had the approval of a drug by the name of revumenib, which is the first therapy targeted towards patients with KMT2A rearranged relapse refractory acute leukemia and it's help now available for these patients. And we're looking at the combinations with this menin inhibitor as well as other menin inhibitors in even the frontline space to combine these agents, which are known in more advanced leukemia to have activity. Can we do better for the patients by incorporating them even in the frontline setting? There was recent data at the ASH Annual Society of Hematology meeting that occurred in December of 2024, where multiple menin inhibitors were presented both in a relapse refractory setting with single agent activity, as well as in combination therapy, both in a relapse setting as well as frontline setting. And so it's a very exciting time that we're having. For instance, two of these menin inhibitors, one is called bleximenib and another one is called ziftomenib. Both of those had data presented in combination in the frontline setting with conventional intensive induction therapy with very high response rates, and more importantly, not just good response rates, but good CR rates and also MRD negative CR. So the deepest remission we can test for being achieved at a high rate for NPM1 positive patients receiving this therapy, but also in patients who have this KMT2A rearrangement. It's a specific genetic rearrangement that can often confer higher risk, that we're seeing high response rates in combination with conventional intensive induction therapy plus these menin inhibitors as well. And so this specific area has been an area of struggle for us because many of these patients were resistant to conventional chemotherapy, and now it seems like we're finally breaking down the door and helping more patients in regards to that.
And do any of these mutations or biomarkers sort of cluster in specific groups of people, again, by age or by gender or by other social factors?
There's a variety of factors that we can see. NPM1 can occur sort of across the age spectrum, if you will. But the other aspect is what mutations or other abnormalities are co-occurring, and that has influence. So NPM1 by itself is thought to be a favorable risk feature. But there's also data that suggests NPM1, when it co-occurs with, say, an IDH mutation or a DNMT3A mutation, that it's the positive impact may take a hit based on the co-occurrence of these other mutations. And for instance, when NPM1 co-occurs with a FLT3 mutation, FLT3 by itself puts patients into a high-risk category, so to speak. But FLT3 plus NPM1 puts them in an intermediate risk, whereas NPM1 patients by themselves go into a favorable risk. So, sorry. So I think it's really not just any single mutation that's driving it, but really looking at the bigger picture of the molecular profile and the diversity even within a single patient's leukemia to try and see what the impact is and open the door for additional therapies. We do know that the KMT2A rearrangement historically has been associated with patients who have seen prior anthracyclines, so part of this therapy-related leukemia that we were talking about earlier. Some patients who receive prior anthracyclines will have a KMT2A rearrangement, and that confers a higher risk disease. And so the availability of these therapies for a traditionally high-risk patient population is going to be very important.
Interesting. My treatment was way back in 2016, and they ran me through the traditional 7+3, and they simply tested for FLT3, which was not present, which was a good thing, and they tested for NPM1, which was also not present, and they said, well, that would be a good thing to have, so you don't have that either. So that's what landed me in the intermediate risk category and made for a more complicated decision, along with a normal karyotype. None of which I understood in the least at the time. I've since come to understand it, but boy, it's a lot to learn and take on. So thank you for that. How and when do you test for these biomarkers?
Sure. So at diagnosis, it's critical when the leukemia is there to help inform prognosis, but also now with treatments, as the treatment landscape has changed over the years, it now can inform decisions on treatment from day one. And so it's strongly encouraged and really a necessity to do this at the time of the initial diagnosis. so that even if we don't have that information back necessarily, if we have to start treatment in an emergent situation, that information can be obtained, because once the patient is in remission, if they responded to that initial therapy and achieve a remission, if we don't have that information, we can't always inform prognosis and or recommendations for things such as whether or not they need to proceed with a stem cell transplant in the first remission. So we check it at the time of presentation to confirm the initial diagnosis and to help us understand the characteristics. But then we also, for some of these tests, will reassess even when the patient is in remission and help us understand the depth of remission. Are patients achieving what's called an MRD, or measurable residual disease remission, a very deep remission, which is the goal of our therapy.
And is this typically done through a bone marrow biopsy or some other technique?
So typically, yes, we would do it at the time of the bone marrow biopsy assessment on the aspirate, the liquid portion that we achieve during that process. But then it can also be done on peripheral blood. There's debates that ongoing, is one more sensitive to the other, but obviously, bone marrow biopsies are not always the most fun to undergo repeatedly, but sometimes a necessity. But we can do some of this testing on peripheral blood as well, especially for interval follow-up and to try and help minimize the number of bone marrow biopsy procedures patients have to undergo.
With that comment, I think it's time to hear from Joseph. And I know it was a crazy time, but how long after your diagnosis before you were tested? And through that process, what were your thoughts about it? Fears, anxieties? What was it like to live through that phase?
Well, I think mine was a little more complicated than average. I actually had a childhood malignancy, and for that, I'd received chemotherapy. And so I think I fell into an atypical category in that mine could have been and may still be a treatment-associated leukemia, which could fall into the higher risk category. But Dr. Strickland, honestly, from day one, I was admitted in the middle of the night after being helicoptered down to his hospital. From day one, he stepped into the room and said, "We're going to look for markers. This is kind of what I'm thinking. And there's even some newer drugs for these different markers." And so we sat down and talked about those markers probably within a day or two of the bone marrow as they started to come back. But in my specific case, because of my previous exposure to chemotherapy, we elected to go with a more aggressive chemotherapy regimen right out of the gate. So I think my case is a little bit skewed, but I think that the genetic markers really guided from there on out his recommendations of newer medicines versus the overall course of my therapy, and even the choice that we ultimately made about stem cell therapy.
Okay. And then back to Dr. Strickland. Now, despite its importance, early biomarker testing is not universally standard. So I'm wondering what kinds of barriers or limitations exist to implementing this as a routine practice, and how can they be addressed?
I think that it's definitely gotten better over the past several years as we've tried to get the word out. It is listed in the NCCN recommendations to be able to get this baseline assessment on all patients at the time of initial diagnosis. But I think it also, has some implications as far as where is a patient presenting and where is that initial bone marrow biopsy being done, and whether or not the hospital system at that time has access to those tests. So it's not uncommon when a patient does present to us after having maybe a bone marrow biopsy done at another outlying hospital, that we do not uncommonly have to repeat the bone marrow assessment to ensure that we get that testing. And so that does sometimes lead to an extra procedure in order to ensure that we have it. But I think that it's all of us, all of the providers that are touching these patients, that are coming in contact with them, really advocating with the hospital systems, with the pathology laboratories, to really ensure that we do get this testing, because it is just critically important in the decision-making process that we have for these patients.
At this point, we're going to shift gears to treatment options, both for newly diagnosed and relapsed or refractory AML. So continuing with Dr. Strickland, once a patient has undergone testing, what are their treatment options? And before we get into specifics, can you give just a broad overview of what has been the standard of care and what we might be shifting to, including targeted therapies or other options?
Sure. So the conventional induction therapy that we use is a regimen called 7+3. And it's kind of easy to remember because some of the first publications about it were actually in 1973. But it's 7 days of one medicine, 3 days of another. So 7 days of a backbone therapy of cytarabine, 3 days historically of an anthracycline, either daunorubicin or idarubicin are commonly used. And that was really the treatment of choice for many years, just those two therapies. And it was sort of a one-size-fits-all therapy. For many years, if patients were not fit enough to receive that therapy, they were often not offered any chemotherapy and sometimes went directly to hospice. And with a diagnosis that the median age is often into the upper 60s, age 67 to 70 is typically where that median age falls, then you can imagine that quite a few patients were sometimes not offered therapy historically if they weren't fit for intensive induction. But in 2017, with the approval of midostaurin, that started to change, at least for a subset of patients, for patients with FLT3 abnormalities that were identified at the time of their initial diagnosis. The approval of that drug added a targeted therapy, a FLT3 inhibitor, to that. And so as a result, that began sort of changing the landscape. Now, that's a subset of patients, about 25 or so % of patients with AML that fall into that category. And since then, we've continued to work towards identifying other markers as well as other inhibitors that may be able to target and take advantage of that. The landscape has changed with the approval and availability of other medicines like gemtuzumab and other medicines that have come on the market to try and help guide us for favorable risk patients who may get an additional antibody therapy, gemtuzumab, in addition to conventional therapy for FLT3 patients that may get a FLT3 inhibitor. There's multiple midostaurin and quizartinib that are now approved in the frontline setting. And so it really has begun to change. But we've also had therapy advances for those patients who are not fit for intensive therapy with the availability of hypomethylating agents, so azacitidine, decitabine, and sometimes even low-dose cytarabine in combination with a BCL2 inhibitor, a medicine called venetoclax. And so we have multiple agents now, and that help guide us based on fitness as well as the molecular profile or cytogenetic profile that the leukemia may possess to really help us hone in and try to take advantage of those markers that are present to guide the patient to the most effective therapy.
I think you may have anticipated some of my next question, but I'll toss it out there nonetheless, and maybe you can embellish some of that. What are some of the most exciting spaces that are either newer options that are already approved or those that are promising in research now in phase 2B or 3 trials? And does it make a difference? Can you distinguish what's for newly diagnosed patients as opposed to relapsed and refractory patients?
Sure. So there's a lot of work that's being done in this space and across different spectrums and different mechanisms of action. There are, areas of opportunity as far as how do we harness the power of the immune system with either antibodies or antibody drug conjugates. We're also developing cellular therapy options as well, trying to whether the patient's own immune system being educated to identify and attack the leukemia cells, or whether someone, a healthy donor, for instance, may donate immune cells that can be engineered to hopefully attack a certain characteristic of the leukemia cell. And we're seeing this across different tumor types and across the landscape of oncology in general. But I would say one very exciting area that we're also dealing with is a new small molecule inhibitor, something called menin inhibitors. And so this is being looked at in a relapsed refractory patient population and showing activity as single agents, being able for some patients to achieve really deep remissions in a relapsed refractory setting. So patients who have seen prior conventional therapy and the disease has persisted and or relapse despite the conventional therapy, and then giving patients a pill. And typically well-tolerated medicine that can, in some cases, achieve very deep remission by itself. And so that's also led to the opportunity of saying, well, if this benefits relapsed refractory patients, can we add these types of therapies to the conventional and frontline therapy? And can we get these medications to patients earlier on to hopefully help them achieve that first remission more commonly and a deeper remission, and hopefully impact overall survival by doing that. And so menin inhibitors are a very popular thing to talk about nowadays in the world of leukemia, and every conference has a session with multiple companies that are developing menin inhibitors because it is a very exciting space.
How do biomarkers play a role in clinical trials? Can they make you either eligible or ineligible for certain trials? How do those two things work together?
Yeah, so it's definitely been an evolution in the leukemia research space, the clinical trial space, and I'll say oncology research in general space. And that, as we mentioned earlier, we're trying to take advantage of the biological characteristics of one patient's tumor, if you will. And so there are a lot of studies that are being so-called biomarker driven. And if a patient's malignancy has a specific marker, then we're trying to get them access to these targeted therapies, or snipers, if you will, that we referenced earlier. And so I think that there are opportunities where, sometimes these drugs may be more effective in a broader scale, but at least with the initial development, we're also trying to enrich the population of patients who are truly going to likely, hopefully, have a benefit from the medications. And so it's really just us trying to take advantage of the characteristics we now can better understand about one person's leukemia, characteristics that we didn't know existed, say, 30, 40 years ago. But now we have the technology to help us identify this and identify it relatively quickly. And that can be instrumental in guiding us to either commercially available therapies or for clinical trial participation, where there may not be something that's already FDA approved to target that.
Okay. So just how does knowing someone's biomarkers impact their treatment choices? And that includes, do biomarkers give you some idea about potential side effects or potential effectiveness of treatments?
The biomarkers can definitely help to guide the decisions on therapy, not so much from a side effect profile, but more so from an efficacy perspective. The way that I think about our traditional therapies are kind of like going to battle with a tank. Tanks can be very effective, but they're not very specific. And so some of these newer therapies, these targeted therapies like FLT3 inhibitors, menin inhibitors, IDH inhibitors, all of these therapies are kind of like adding a sniper to the mix. And hopefully by, going to battle with maybe both tanks and snipers, if you will, hopefully we can have a more effective outcome in the battle against this malignancy.
Okay, turning it back to Joseph, I'm curious, how did you work with Dr. Strickland to decide on the best treatment options concerning the biomarker testing and how it influenced treatment choices? How did you collaborate and work together?
Well, I think right out of the gate, once again, we kind of appreciated that I was going to start off in the high risk category. So we started with some, the typical chemotherapy regimen that he was speaking about. But then as my biomarkers started to come back, really every day on rounds, I would kind of anticipate yet another conversation with Dr. Strickland and his team. And so as the final testing came back, I kind of found out I was one of these lucky people that might be a candidate for one of the new menin inhibitors that he's talking about. And so, that was very exciting. This idea that potentially I could, stealing his phrase, start out with a tank and a sniper right from the beginning. And so that's the route that we elected to go with me, is it started with both traditional and one of the new menin inhibitors.
That does sound promising. But nonetheless, what were some of your biggest concerns during the process? It had to be an anxiety-provoking time.
Oh gosh, I don't know that anxiety even covers it. It's an interesting thing, and it sounds like, Steve, you might know yourself, but you go from somebody who's healthy and active and surrounded by people you love, and you're kind of put in this unfamiliar environment and told you really can't leave the floor because you're going to be neutropenic in several days, and so you can't really have contact with the world or your typical support network. And so as you're every day discovering a little more about your disease, there's really very few familiar faces around you or familiar environment. So I think it's very a very, very anxious time. But at the same time, I found hope. in some of these. As we talked about some of these findings that I could have found out I had multiple mutations, and that I was a candidate for none of the new drugs, and that we were going to try chemotherapy, and then if that didn't work, here was the backup, and here was the backup for the backup. So, I think there was just no end to the initial anxiety, if you will. And so really about 3 to 4 weeks in is when everything's back and you're starting to learn kind of what the next 3 to 6 months of your life looks like. And only then did I feel like you could kind of settle in and realize the path that's in front of you.
Wow. And Dr. Strickland, on your side of this collaborative issue, what are some of the most common questions that you get from patients going through this process?
Yeah, well, as you can imagine, there's a lot. It's such an overwhelming time for many patients. In acute leukemia in general, I think is kind of cruel in that way, in the sense that, patients don't go into the hospital or the clinic expecting to have that diagnosis. They walk in with some non-specific symptoms and often think there's something else. I must have a cold. I must need antibiotics. Or maybe they are having chest pain. Maybe they think it's their heart, but obviously, we all know someone who's had some cardiac procedure and they're out, living their life and doing fine in a pretty short period of time. And so, patients, their families are often say, okay, you're currently at this hospital. We're going to send you to a hospital that's more of a leukemia center. You're going to undergo this biopsy. And then before you have time to even digest the word leukemia or cancer in general, we're saying, okay, we're going to start therapy in the next day or two, and just talking about all of the side effects, really before many patients and their families have time to process the information. Some other malignancies, you say, okay, there's a lump or a bump or a spot on an x-ray or a scan. We're going to set you up for a biopsy. We're going to set you up to see a surgeon. We're going to set you up to see this person. And patients and their families often have weeks to digest that information and come to terms with what it means. But in the world of acute leukemia, we often have, days to maybe a week if we're lucky, but often it's less than a week when all of this is happening. And then asking patients and their family members to process, okay, well, here's a clinical trial. We're going to, mention this to you, or here's all these different therapies, and this is what we have to offer. It's just a very overwhelming time, sometimes for the providers as well as for the patients. And so I think it's really just trying to navigate, and walk hand in hand with the patient and their families as we get this information. What are we looking for? What is it going to mean? How are we going to use this information? And in this particular case, we took the history. We understood that there was although it was quite a few years ago, that this prior chemotherapy exposure happened, the possibility that this was a therapy-related leukemia. And so our choice of induction therapy was guided on that. And then some of the biomarker testing came back. And as a result, this particular trial that we were able to access with the menin inhibitor allowed patients to start conventional backbone therapy. But if we had the information about the biomarker being present, that we could then, enroll the patient and get them access to this other targeted therapy, so to speak. And so it's really a huge effort to try and coordinate this, and obviously communication and coordination even with the sponsors of each trials, to set trials up in a way so that we have a little bit of flexibility on the front end, and we didn't burn a bridge with someone who we wanted to and felt the need for starting therapy quickly, but yet still could have access to some of the more cutting edge therapies that are coming up as well.
So we've talked about providers and patients. Let's bring in a third group here, because at the patient story, we've often talked about getting loved ones involved in the process. So Joseph, can you say a bit about who were your caregivers or your care partners, and how did they help influence or inform your decisions?
Well, my wife is an office manager for a medical group, and it was really beautiful that they kind of gathered together and said, you stay with Joe and you can manage your office by computer. And so she really stayed by my side that whole time. And that was just phenomenal, and honestly really helped me make a lot of the tough decisions. In addition to that, I'm a physician as well. And so I had a lot of access to a lot of different docs that I could call and ask about, certain things. Even something as simple as, I called a buddy of mine who's a vascular surgeon when I was picking out whether I wanted a portacath or whether I wanted a temporary line in my arm. And so, I kind of pulled some strings that way as well, to make my decisions. But ultimately, he's sitting right here, but I would say behind his back, I felt so comfortable with Dr. Strickland. I just felt like when he entered the room the very first time, he laid it all out. I felt like there was nothing left off the table. Here's the goods, here's the bad, here's all the options. And then as more information came back, I felt like he immediately updated me on what the new information was and what the options were. So me and my wife, Heather, really, we felt like we had all the information we needed to make the best decisions for my care.
Let's change the focus here and talk a little bit about clinical trials. I was in a clinical trial myself. It was a very passive kind of trial, but we got to the point where I decided I wanted a transplant, but we had to select a donor. And I had a half-matched sibling, my brother, and they said, well, that's a potential donor, but we should also consider umbilical cord blood donors, which sounded like science fiction to me, but they convinced me it was a plausible alternative. So I said, which is better? And they said, we don't know, but we have a clinical trial to figure that out, and you can join the trial if you want. And since I had no basis for deciding on any other basis, I said, sure, put me in the trial. And they randomly assigned me to the cord blood option. So my brother as a donor was off the hook, and my fate was in the hands of a mother and baby who donated their umbilical cord somewhere in the world in the last few years. All that ended well, but ironically, years later, the results of that trial came out, and they slightly favored half-matched siblings as opposed to umbilical cord. But I was an N of 1, and the umbilical cord blood worked for me. So clinical trials are crucial to figuring out what works and who benefits from what works. So, Dr. Strickland, when and why are clinical trials a good option for a patient, and how can patients find and evaluate trial opportunities?
Sure. I'm probably going to be biased, but I will say that clinical trials, when available, are going to be appropriate for any patient with acute leukemia and every patient with acute leukemia, hopefully. In that we know we've had drugs that have been around since the early 70s or even earlier that we've utilized. But while some of these agents can be effective in getting patients in remission, we know that for many patients, cure can be elusive. And unfortunately, the majority of patients with acute leukemia do end up relapsing. But that's also because many of them fall into an intermediate or higher risk group. And so when that happens, we know we can get them in remission, but the question is, how do we keep them there? And that's really where a lot of the efforts are, and to try and modify the frontline therapy to achieve deeper remissions, and hopefully remissions that are going to be more sustainable, and clinical trials that if they have well-tolerated medications, maybe those medicines can be used even as maintenance therapy to allow the patients to stay on some low-intensity, well-tolerated therapy for a longer period of time, and hopefully exhaust that leukemic clone altogether is kind of the idea. So I'm very passionate about the idea of clinical trials. Obviously, I'm going to be biased because I'm a clinical trialist at heart, but at the same time, I think it's really because we want to offer the best available therapies to our patients. And as we get the information about the biology of any one patient's leukemia, if we have a trial option, we really want to try to swing the pendulum as much in their favor and give them benefit. So, but we also know that there are patients who are treated all throughout the country, all throughout the world with leukemia, and not every place has access to that. And so sometimes we also are dealing with patients in a relapse refractory setting. And I think at that area, it's even more crucial to try and gain access to clinical trials for patients, because historically, many of our relapse refractory therapies have about, somewhere in the range of maybe 30% chance of getting the patient in remission, meaning the majority of patients in a relapse refractory setting will often not achieve remission with that salvage therapy. So needing better therapies, more effective therapies, and or combinations of therapies to take advantage of the biology of the disease is just crucial to be able to offer to patients.
It sounds like your patients are going to hear about clinical trials, but for other patients who may not have a doctor who's a clinical trialist, if that's the right word, how should they go about finding and evaluating clinical trial opportunities?
Sure.
What's a good source of information?
Yeah, I think, obviously there's plenty of resources out there now with the internet. Obviously, you have to be cautious about what you Google, so to speak, or find on whatever search engine you desire. But at the same time, there is a lot of resources out there. The Leukemia Lymphoma Society is instrumental in trying to help provide patients with education about opportunities, and they obviously support quite a bit of research as well. There's a website, clinicaltrials.gov, where all clinical trials, at least in this country, are registered. And so you can, with their search engine, you can input a few words, the diagnosis that you have, and often get information about trial opportunities that are out there. And there's also additional information about the sites that are participating in each one of those different clinical trials. So their information is out there if you know where to look. But I think the biggest thing is talking with your doctor, talking with your oncologist, and asking that question. Patients need to be informed and empowered to ask the question about, is there a leukemia center near me? Where is the nearest leukemia center near me? And what are my trial options? And so trying to get away from this idea of people thinking they're so-called guinea pigs and they go into a study, and realizing that we're not here trying to experiment on patients. We're here trying to offer them availability to the most cutting-edge therapy that they can have access to. And that's really where my passion is. It's the trial data is one aspect. When we look at hundreds or thousands of patients that go on the study, we will be able to inform decisions about populations. But when we're meeting one-on-one with a patient, it's about what can we do to help that individual patient, and that's where the offering for a clinical trial comes from.
Thank you. Given that the typical or median AML patient is in their late 60s, maybe around age 68 as a kind of median age, does age impact the decision to encourage them for a clinical trial?
It does. It impacts it in several ways. Obviously, we know that age is not the best determination of someone's performance status or fitness, if you will. But it does play a role as far as the wear and tear that their other organ systems may have had, and how well can they endure the side effects associated with an intensive therapy approach. So I think that we also know, I should say, that patients who are on the older end of the age spectrum, who are in their mid-60s and above, tend to have higher risk disease. And so we often are faced with, even if we have the opportunity to give them intensive therapy, the majority of those patients are not going to be cured with that therapy. And so they're going to be faced with potential relapse. Now, if they're a transplant candidate, we try to get them to a transplant. But again, as we get on the more, I say, mature range of the age spectrum, if you will, that it makes the availability of something like a stem cell transplant and the intensity that goes along with that very challenging. And so we need more effective therapies that can be used, for instance, as maintenance therapy. And we do have that nowadays with patients who are able to receive hypomethylating agents plus, say, a BCL2 inhibitor, venetoclax, which is approved for unfit patients in the frontline setting. We have access to that therapy now, and that can be used as maintenance. But what do we do for patients when they progress on that therapy after the therapy stops working? And that's also another opportunity for clinical trial enrollment as well.
Now, Joseph, you're a little bit on the young age of the spectrum here for AML, but how did clinical trials come up in your treatment? What did you know about them, if anything? How did you get familiar with them? How'd that go?
Yeah. So, I think day one, the discussion was opened about clinical trials and some of the possibilities before we even knew what my mutations was. We immediately started talking about the opportunity of clinical trials. We talked about kind of the whirlwind of the diagnoses and learning it and trying to navigate and come to terms with it. So I really almost kind of felt like I was in such shock that I was happy with any opportunity. So unlike a traditional cancer course, like Dr. Strickland was talking about, where, hey, you're going to go see a surgeon and then 2 weeks later an oncologist, and 2 weeks later make a choice. To me, there was such urgency that to hear that I had options, both in the traditional sense and the trial, gave me comfort. And the fact that they were going to be used simultaneously, we're going to use this traditional chemo induction therapy, which we know has some efficacy, but then in addition, we're going to consider you for all these trials, and these are going to be parallel treatments. In no way, shape, or form did I feel like, I was being experimented on or anything of that nature. I felt very comfortable with it. As the trial has gone on, I have loved it. There are some impacts of it. There's a lot of checkbox, if you will. So I think if I understand Dr. Strickland correctly in some of our visits, I probably get to see his clinic staff a little more often than the average AML patient who's in remission. I get to have a bone marrow every 3 months, which is probably not on everybody's bucket list, but a small price to pay. And so, there's definitely some check marks and some impact to your quality of life later on. But I just feel like it's a very, very small price to pay. The clinical aspect, as far as side effects goes, I've been surprised. I really, really felt like I've had minimal side effects with this drug. There was a little bit of variation in my clinical trial, almost as if they were trying to figure out the highest effective dose. And so there was a little bit of a dose escalation partway through my trial where they tried me on a higher dose, and I didn't tolerate that very well. And Dr. Strickland and his crew was very amenable, along with the company who runs the trial, is saying, well, go back down to the dose you're tolerating. And so that was really the biggest bump I had in the road in my treatment, was just we doubled and even tried to triple the dose, seeing if it could be tolerable, and it just wasn't for me. But overall, I've had just a phenomenal experience with this trial that I'm in.
Great. Dr. Strickland, can you just mention or describe a couple really promising trials that are happening right now?
Sure. I think that, there's plenty to be said, that we could probably, spend much more time in at different sites across the country with all kinds of different trial opportunities. But I've been fortunate to be able to be a part of several, and also to see colleagues present data on theirs as well. I mean, there are trials that are being run. For instance, there's a trial called the SAVE trial, which is looking at a triplet oral therapy for patients. So it's a oral decitabine plus venetoclax plus a menin inhibitor, revumenib, in a relapse refractory population that is taking away the need for daily trips back and forth to a clinic to receive chemotherapy, for instance. And as some of these agents have oral formulations, being able to use a strictly oral formulation and combination therapy to hopefully help to impact patients, and that's shown very nice response rates as well. And so I think it's really opening the door for how do we cater to the patients and to the logistics of their lives as they are truly living with this disease over time, because we know that historically there's a lot of time spent in the hospital, a lot of time away from work and things of that nature. But there's also, other trials, for instance, as I mentioned, the incorporation of the menin inhibitors into frontline chemotherapy. And so there's a 7+3 plus ziftomenib that we have been fortunate enough to participate with. And for patients who are NPM1 positive, the data that was presented last December suggested that 100% of patients who had NPM1 positive disease were achieving a true CR, and about 76% of those patients were achieving MRD negative responses. And so that's very encouraging. Now, it's small numbers of patients. We still have a lot of work to be done, and we'll see if that 100% holds up or not. But nevertheless, the fact that the majority of patients are seemingly benefiting from the therapy is very encouraging. We also have, access to relapse refractory studies, and I briefly mentioned cellular therapy studies. And so we've been very fortunate to participate in some of these and provide access both here in Nashville, but also across our Sarah Cannon network of other participating sites within our network that have access to some of these therapies as well, for engineered immune cells from healthy donors to give to patients. And they've been engineered to to attack a certain characteristic that's commonly found on AML cells. We recently presented data that 4 of the first 7 patients to ever receive this product, this cellular therapy product, 4 of the 7 patients achieved a deep MRD negative remission. So that's very encouraging for patients who have had relapsed refractory disease. Again, a lot of this is still in its early stages, but it's just a testament of what we're trying to do and where access to clinical trials can really sometimes be better, hopefully, than what we have on the proverbial shelf and offer patients opportunities that they otherwise wouldn't have.
So, Joseph, can you say something a bit more specific that might provide some guidance to patients who are trying to figure out, should I think about a clinical trial? How do I decide about a clinical trial? How do I fight my way through the consent form? What's it like from the patient's perspective to go through that whole process of deciding and entering a trial?
Mm-hmm. I had a really good experience with that. I had multiple staff members come to me. I thought they did a phenomenal job explaining the trial. They sent a representative from the pharmacy up to answer any questions about what the side effects potentially could be of the traditional and even the immunotherapy they were offering me. So I thought that was great. Logistically, I found it, I found it really, really easy to navigate the forms because you have an expert sitting right beside you kind of explaining this is what this means and that's what that means. I will share personally, probably what gave me the best feeling on my trial, and Dr. Strickland even alluded to this, is, I was one of the menin inhibitors, NPM1 positive was my genetic makeup, is they presented my trial to me as there's not half of you are going to get the medicine, the other half's not. It's not like they're going to flip a coin and say, maybe you're getting a fake sugar pill and the other half's getting the real medicine. The way it was presented to me on my trial was, here's a medicine. We know it works. We know that in patients who are refractory, this already works in them. Our question on your trial is simply, if we give it to you at the very beginning, do you go into remission quicker and a deeper remission? So, I think before I came into all this, clinical trials are a little bit of a black box. You just don't know what's going to happen in them. And the word experimentation, I think, is a daunting word. So, am I going to go into something that they don't even know what it does? They don't even know what the side effects are. Am I going to get the real pill or the fake pill? I don't think all clinical trials are like that, obviously. And mine was quite the opposite, is we're giving you a medicine that we know is efficacious, and we're just going to see how efficacious it can be if we transition it up in your treatment. So to me, I found a lot of comfort in that.
Thank you for that. We have just a few minutes left, so we're going to begin to wrap up here by focusing on what might be some key takeaways from what we've heard today. And in that case, I'm interested in just what are your final thoughts? If there was one thing you wanted someone newly diagnosed with AML to know about testing and their treatment options, what would that one thing be? And Joseph, let's start with you.
So I think the best advice that I could give to a patient who's just been diagnosed, and this is the advice that I've myself followed, and I think it served me very well, is access great resources. And I see that even in my practice as a neurologist, is that people come in and they Google search their disease and they come in with all this preconceived bad information. And that's so scary, so very scary. But there's really great websites out there and there's professionals out there that really can give you good information. And so I know when I headed into this really dark time with a lot of confusion, I made a really big promise to me and my wife that we weren't going to get on the internet and just search out all these really poor resources. We were going to trust in Dr. Strickland and his teams and his protocols. And if he, offered us resources, different websites that we could look at, that we really restrict our vision and our knowledge to those. And I feel like you can get a lot better solid ground under your feet by starting there versus the really huge cloud of misinformation that is the global internet.
That's one pretty good answer. Dr. Strickland, what's yours? One thing you think newly diagnosed patients with AML should know about testing and treatment options?
I think that, the thing that I would try to get out there and let people know is there are options. And I think too many times people hear the word leukemia, and I hear this all the time. They they come in very distraught. They're like, well, I know there's no cure for that. And so there are a lot of unfortunate predispositions or just sort of misnomers out there as far as what we can do. And that may be because they had a family member from years ago that was told they didn't have any treatment options. And who knows what the specifics were. But I think we have many more opportunities available to us today. I think that approaching this with an open mind to try and understand what are the options, and hopefully with this and obviously resources from Leukemia and Lymphoma Society, obviously what the patient story is doing here by putting what a wonderful face and story to this disease, in the sense of what can we do and the success that we can have if we just have the opportunity. So I think we want to empower patients. We want them to be informed. We try to inform them with our discussions early on. I think using reliable websites in order to do that. But I think just approaching this as open as we can. I mean, I think that Dr. Ashburn's story is to me, it's just such an incredible one of, and I'll go off on a tangent for just a minute, but just to say, he alluded, he was at a bike race. He was living his life, not having any idea of what was going on underneath the surface until some of those symptoms and side effects developed. And then the whirlwind tour of being transferred across state. And I will tell you that it was very gratifying to me that one time when I picked up the phone to call him and ask him a few questions, he was very out of breath. And I was very concerned at first about what was going on. And I said, "Are you okay? What's going on?" He goes, "Oh no, I'm at mountain bike practice. And I was just teaching middle schoolers, I think, at their mountain bike practice." And so, the impact that I would say that the therapies we have nowadays and the access to the clinical trial to take someone who had to basically stop racing because of symptoms to the point of getting them to the point where not only is he able to do the things he loves, he's passing that on, both with his practice, both with coaching middle schoolers and mountain biking and things of that nature. That's the opportunity we want for all patients to have, to really get back to their lives and live their lives to the fullest. And I do think participation in clinical trials and getting the best available therapies as possible, hopefully is going to open the door for more patients to do that.
That's a nice note to end on. We need to wrap up. I want to say thank you to Dr. Strickland and Joseph for sharing their insights. We hope this discussion has provided you with valuable information. We encourage you to continue following the latest advancements in the field and to discuss your options with your healthcare providers. Have a good rest of your day.
All right. Thank you so much to Steve, to Dr. Strickland, to Joseph for spending your time with us today on this discussion, featuring so many perspectives here. So hopefully this was really resonant with a lot of you who showed up today, hopefully with every one of you. And we want to keep the conversation going. First of all, we want to do more of these. And so a survey is going to come up right after this window closes. We want to hear from you, what you enjoyed, but maybe more importantly, what we can do even better, what more you're looking for in terms of educational content, connection, anything to do with programs, patient stories, things that'll help you, in your life now after a diagnosis, whether you're a patient, your partner, or otherwise. And again, the survey should not take more than a few minutes to fill out. We once again want to thank our sponsor, Kura Oncology, for its support of this program. Again, it really helps us to make sure that we provide these more often and always for free for our communities. And again, that today is not a substitute for medical advice, that the patient story retains full editorial control. So thank you all so much for joining us today. We hope this is helpful for you, that you're walking away with more feeling of being empowered, because you should be asking the questions. This is your life, your loved one's life. And we hope to continue having more of these conversations and to see you at another program soon. So for the patient story, I'm Stephanie Trong. Thank you so much and take good care.